This is Lawrence Sherman with the Global Multiple Sclerosis Academy. Joining me in discussing the current landscape and perhaps a look towards the future is Dr. Jiwan Oh. Dr. Oh is Assistant Professor, Department of Medicine at the University of Toronto, scientist at the Keenan Research Center of the Li Ka-shing Knowledge Institute of St. Michael's Hospital, and neurologist in the Division of Neurology, Department of Medicine at St. Michael's Hospital here in Toronto, Ontario, Canada. Thank you for allowing us to come into your office and talk with you today.
Thank you for having me.
Oh, it's our pleasure. So we were chatting a little bit before and talking about sort of the educational state of need in multiple sclerosis and that varying audience that's out there. So I have just a few things I want to talk to you about, and I'd like to touch on the journey of the patient and the journey of the healthcare professional and as they intersect in sort of optimizing that care. Lots of things have happened in the past few years, and what do you think some of the most significant developments in MS care have been in the past few years?
Well, I think from a clinical standpoint, first and foremost, it's that our treatment options have greatly expanded. In the last 5 years, we've seen the treatment options for relapsing remitting MS double. And this is a significant change in comparison to about 10, 15 years ago, where the only options we had for patients were injection therapies, but now we have oral therapies, we have a number of infusion therapies, and we have therapies with very different mechanisms of action. So it's a great benefit for patients just because it allows people to have a bit more of kind of a personalized treatment regimen.
Sure, and that's always an interesting point, that personalized patient-specific treatment regimen. What are some of the factors that you consider when selecting an agent, either initially or when you're changing or adding?
Well, first of all, it has to do with the degree of disease activity. In most patients, the degree of MS disease activity is relatively mild or moderate, and in these settings, we have a bunch of treatments that we typically use first line, and this is based on the fact that they seem to be very safe medications. In a minority of patients who have extremely active, severe disease from the beginning, we tend to jump to more potent therapies that do have some potential risky side effects. But in the majority of patients, it's really a group of agents that we know as the first-line therapies, and there are a number of therapies that are in there, and often we do leave it to patient preference because some patients will opt for the convenience of oral therapies, even though they don't have as much of a long-term safety track record. But some patients will opt for injection therapies because they don't mind giving themselves injections, and they very much like that there is a long-standing track record of safety for many of these drugs that have been on the market for almost 20 years now.
Right, so that safety plays a role for both of you, both the patient and from you as a provider and caregiver.
Yes, definitely.
When I think about multiple sclerosis, I think about a disease that's so difficult to predict and prognosis, and so you've made your initial diagnosis and then you use techniques, maybe MRI, to follow the disease course. Are there some changes happening in MRI that are going to make it even better as you follow the course of a patient's journey?
Yes. Well, I do quite a bit of MRI research, so I probably have somewhat of a biased view about this, but I believe that MRI has really revolutionized the way that we treat and manage patients with MS. Technologies are getting better with MRI, and so we're able to look at the brain in more detail. There's a number of sequences that are now used mainly for research purposes, but many of these sequences likely will be used in the clinical setting once they're validated for use. And this will just enable us to monitor the disease more accurately and to be able to detect subclinical disease activity in much more of a rapid way and to make appropriate treatment decisions based on this.
Well, that's interesting. Can you tell me a little bit more about some of these research protocols and how you see them impacting the clinical practice maybe 3-4 years from now?
Okay, so there are a number of advanced sequences that are under development. Some examples include sequences like diffusion-weighted imaging, magnetization transfer imaging, functional MRI, more detailed ways to look at specific structures in the brain and the spinal cord. And again, they're not used typically in the clinical setting, but we do know that they are much more sensitive and specific to underlying tissue changes than what is typically used clinically. So when we are able to develop these techniques so that they are reliable enough to be used clinically, they will allow us to see if a patient is responding appropriately to treatment much more rapidly than we would be able to do using typical clinical sequences. They will be able to help us to predict how certain patients will do. So early on in disease, like you said earlier, it's very difficult to predict how a patient will do, but the hope is that some of these technologies will enable us to decide who needs to be on a more potent treatment earlier rather than later, and who is okay being on a relatively mild treatment.
So as we think of that journey of the patient with MS, what are some of the greatest challenges in the care of that patient?
Well, I think the kind of approach to the clinical care of MS patients is evolving right now. Even up to, I'd say, 5-10 years ago, and even currently in many centers around the world, MS is still, purely monitored from a clinical perspective. And obviously that does make the most sense. But I think one thing that has come to light in recent years is that there is a lot of clinically silent disease activity that occurs, and this is where it is so important to use adjunct tools like MRI, OCT, other things that will help us to get a better gauge of what exactly is happening in the disease. And so really, I think one of the biggest challenges in MS is that the way you treat and monitor patients is evolving, and it differs across centers. I think we need to have a uniform way to do this. I think there should be guidelines as well as to when we know for sure that a patient is not responding to a medication, when we know for sure that a patient is stable and they're okay to continue on the same medication. And so just with a lot of evolution in the options that we have, as well as the tools that we use to monitor disease, I think it's a challenge in a way to come up with a standard of care that will allow us to provide optimal medical care for all MS patients.
It's interesting. You mentioned something about sort of tracking the disease. One of the things that we encounter in some of the educational assessments that we do is the fact that there's a gap in what the patients tell the physicians and healthcare professionals. And do you find that there may be some episodes that go undocumented because the patients just say, oh, this is supposed to happen, and then let it go?
Definitely. And I think people have very different thresholds of reporting symptoms. So there's a certain type of personality where they will list every single symptom that they experience all the time and will report these. And then there's other personalities that just tend to minimize and ignore everything. And so when you base your clinical assessment purely on what a patient reports to you, sometimes you're not necessarily getting the most accurate picture of what is happening with the disease. And this is why I think it's so important to utilize other adjunct tools that may be more objective to monitor how people are doing.
Do you find that that's an opportunity for other care team members to get involved and actually interact with the patient and maybe help elicit some of those hidden episodes?
I think so. I mean, I think ideally, MS care should evolve so that it's a multidisciplinary approach, because we know that MS is a multifaceted disease. So, if there was, say, at every clinic visit, a physiotherapist or an occupational therapist who could also assess the patient and perform specific tests that could help to elicit any sort of subtle physical deficits that may not have come out during the routine kind of history and neurological exam with the physician, that would be helpful. If there were cognitive tests that were administered to all patients so that we could pick up on subtle changes in cognition that have occurred between visits, that would also be very helpful as well. So those are kind of some examples of how a multidisciplinary approach would help us to monitor patients and provide better care.
That's awesome. And you've alluded to the movement and evolution of MS care. Where do you see it going in the next 10 years?
So this is probably my ideal version of what I hope it will look like in 10 years. And obviously there are a number of restrictions that will prevent this from happening, including the availability of funds and things like that. But ideally, I do think MS care needs to evolve into a highly specialized multidisciplinary approach. With the number of treatment options that are becoming available, and again, with better tools to monitor the disease and better tools, hopefully, to predict how people will do, as well as a number of treatments that will have some very serious side effects, I do think that MS care will evolve into a care model somewhat like cancer care. So I do believe that most MS patients should be seen at large academic centers where there is a large MS clinic with specialists in the field, just because it will be very difficult for people who do not have specialty training to be able to, kind of know all of the available treatment options well enough to prescribe the right treatment to specific patients. I do think in these centers we should be hopefully able to provide a multidisciplinary approach like we discussed earlier. So ideally there should be an occupational therapist, a physiotherapist, a physiatrist, a neuropsychiatrist on site so that we can provide the services that our patients need kind of in a one-stop shop kind of way.
Let me ask you to put a different hat on for a second. Let's say you're not based in a large academic MS care center, but you're a solo practitioner or you're in a small group somewhere where there's not a close by MS center. What do you think will be happening, and be optimistic here, for those folks in the coming years?
So I think in those settings where patients need to travel large distances, a shared care model would be appropriate. So, and we do kind of informally practice a form of that right now. So we do have a number of patients at our clinic here that come from various areas that are quite remote, often have to fly to come to our center, but usually there is a community neurologist, and so the community neurologist will refer the patient to our clinic. We do make the decisions on what sort of treatment the patient should be on, what sort of monitoring they need to do. But then once the patient is stabilized, they can follow up with their regular neurologist. And then if any problems arise, they can always be sent back to us. So I think that's an ideal shared care model that minimizes the amount of travel that a patient needs to do, but still provides them with the subspecialty care that they need when they need it.
Do you have guidelines for those community-based neurologists that you provide to them, and how would they find out about the opportunity to have a shared care model?
For now, it's done mainly on an individual basis, but typically what I do is when I am writing back to the community neurologist, I provide them with guidelines as to what sorts of things they should be monitoring in terms of blood work, how often an MRI should be done. And we often do communicate not only through written communication, but also a phone call. But I think this process needs to be much formalized in a way, just so that all patients who do have MS do at least have access to a specialty center when they need it.
Sure. So let me put you on the spot a little bit. What are the top 3 things you would tell the community-based neurologists who may be watching this video that they should be looking for in the types of MS patients that they should refer quickly, and should they be referring all of their MS patients?
So in terms of patients who they should be referring quickly, so I'd say a few red flag things they should look out for are people who have very active disease. And by active disease, I mean people who have frequent relapses. Relapses that are often disabling, meaning that they do not recover completely from them, and people who have a lot of activity on sequential MRIs. So these are people who develop a large number of new T2 hyperintense lesions or gadolinium-enhancing lesions. And these are the types of people that really need to be seen sooner rather than later, because we do have a number of newer treatment options that are very potent and are very suitable for people like this, where you really need to do something to shut down the inflammatory disease activity quickly to prevent irreversible disability. In terms of whether they should refer all of their patients, now that is a challenging question, and in a way it will depend on the resources that are available at the large subspecialty centers. Ideally, though, I think every MS patient should at one point be seen at a subspecialty center. And it's just because I think it's only fair. They should be assessed just to make sure that all of the appropriate, they're on the appropriate treatment, they are being monitored appropriately, and that any sort of other multidisciplinary benefits that they can have been addressed. I don't think necessarily people who have stable disease and relatively mild disease necessarily need to be seen regularly at subspecialty centers, but I do think a one-time visit often is very useful because there are a couple suggestions that can be made that patients can continue to follow that will make a big difference.
That's great. Now let me ask you, again, putting on your thinking cap for a moment, what is the one thing that you think could be done that would greatly benefit the care of MS patients?
So, I mean, this is, I'd say, I'm going to answer that question in two parts. So right now, I think the one thing that really is needed in the field is a treatment for progressive MS. When I talked about all of these treatments that have become available and how in the last 5 years our treatment landscape has doubled, this is only for relapsing remitting MS. And luckily, relapsing remitting MS is the most common type of MS, but there are a distinct population of people that present with progressive MS, and then a number of relapsing remitting MS patients eventually do convert to secondary progressive MS. And I have to say that is by far the most difficult part of my job. Because the only thing we can do for these patients with progressive MS, and these are the people that tend to have the most severe disability, the only thing we can really do at this point is provide, symptomatic therapies for, their spasticity or their fatigue or their depression, things like that. But there is no agent that I can offer them where I can tell them that it will actually help to alter the course of their disease. And it's really, really difficult. So it's not for all MS patients, but I do think in the field itself, the number one thing that we need right now that will dramatically change things is a treatment that works in progressive MS. And luckily, there are international efforts being made to try to make this happen. But in terms of the clinical care of MS patients in general, I know I keep repeating myself and probably sound like a broken record, but I really do think we need to provide clinics where we can provide a one-stop shop multidisciplinary clinical care approach because that would lessen the burden of having to attend visits for patients, and it would allow them to address all of the things that make a huge difference. So obviously as a physician, I'm the person that makes the decision about what disease-modifying treatment people need to be on and various symptomatic therapies, but there are a number of other things that we just don't have the time to address in clinic. And these things include things like wellness, diet, exercise, all of these things. And I really think approaching each clinical visit in a holistic manner like that would make a huge difference for patients.
Great. So we've covered a lot in a little bit of time. And I guess we can sort of sum it up that you talked a lot about personalized patient-specific care. You talked about considerations of safety from both the patient and the healthcare professional perspective. You talked about some prognostic factors. And then you talked about that interprofessional team bringing everybody together in that one-stop shop. Is there anything we didn't cover that you'd like to talk about?
One thing I should say is another thing in MS that would be extremely useful is when a patient is diagnosed, if we had some sort of marker or tool that would help us to guide who should be on a really potent treatment from the beginning to prevent irreversible disability accumulation and who should be maybe not even on any treatment or a milder treatment, that would be incredibly beneficial as well. And right now, the tools that we have to do that are crude at best. We have a few kind of clinical prognostic factors that seem to have panned out in longer observational studies. We have, some studies suggesting that your baseline MRI lesion load will predict how you do, but we don't have this kind of magic bullet marker that really is ideal in being able to predict these things. And so I think that would be another real benefit in the clinical care of MS patients if we were able to identify a tool like that.
Well, maybe the next time we talk on camera, we'll be able to say, look what we've got.
That is the hope.
Well, thanks for letting us come in here and invade your space and chat with you today.
Thank you very much. It was a pleasure.
That was a great interview and a lot of educational benefit from it. We hope that you'll be able to visit us at our Global Multiple Sclerosis Academy booth at ECTRIMS this year.